Be seated. We will now be having the ANTC Distinguished Lecture by Dr. Peter Hutchinson. He'll be talking about rescuing the injured brain, monitoring and clinical trials, challenges in the management of global neurotrauma.
Whose phone is this? Anybody's phone?
Good morning, everybody. Can you hear me okay?
Dr. Peter, very good morning to you. Can you hear us?
Good morning. I'd like to commence with an apology that I'm unable to join you for a family health issue, but I'd be very pleased to receive an invitation, and I've spoken to Professor Deepak Gupta, and I would very much love to attend ANTC in 2024 and visit you all in Delhi. So my understanding is that I'm due to give two lectures. There's a lecture entitled Rescuing the Injured Brain for 20 minutes, and that is on some of the evidence involved in the management of traumatic brain injury. I discussed some of the issues in terms of neuromonitoring in the pre-recorded talk yesterday. And then we have a second talk on global neurotrauma for 10 minutes. So with your permission, I would like to commence with the 20-minute talk, Rescue the Injured Brain. Well, I showed this slide during my talk yesterday. The subject of the current talk today is going to be around some of the evidence, particularly in relation to clinical trials, focusing predominantly on surgical trials, so in the operating room. Head injury, as you're aware, has been around for many years. It's prehistoric times. We know about trephination, the year of Hippocrates, the Middle Ages. This is Percival Pott's elevator for depressed skull fractures, then through anaesthesia, CT scanning, road safety, and then in the UK at the moment we have the nice head injury guidelines and various parliamentary groups trying to improve legislation, and that particularly relates to prevention. We had a big problem coming in the UK in head injuries sustained particularly from electric scooters. As you know, traumatic brain injury has a variety of causes, and in the United Kingdom we are seeing a change in the epidemiology of traumatic brain injury, with less road traffic collisions, but more falls, particularly falls in the elderly on anticoagulants, sadly assault, and there's a huge interest now in traumatic brain injury as a result of sport, predominantly mild traumatic brain injury and concussion, with rugby of particular interest, but there's also some interest that we're receiving from the cricket fraternity as well. So I'm going to talk predominantly about trials in this talk. As we know, head injury can be classified by mechanism, severity, and morphology. My talk will focus predominantly on the management of moderate and severe injury and some of the challenges around these neurosurgical mass lesions. Classically, the management of neurotrauma has been very much focused on operations for removal of hematomas, but as I said yesterday, with the introduction of intracranial pressure and other monitoring, there is increasing interest in intensive care, but that poses challenges in terms of the evidence. And you'll recall that one of the challenges that we face in these patients is intracranial hypertension and its management and the impact that has on cerebral blood flow and oxygen delivery. We know the targets for ICP and the challenges that we have to try and maintain these targets. and that's been attempted through a number of different therapies. There have been medical interventions, and I discussed the ICP protocol yesterday, but sadly there has been no magic bullet, there has been no medical neuroprotective agent that has been shown to improve outcome in traumatic brain injury. There have been attempts at other therapies such as hypothermia and the medical management of ICP. Hypertonic cellular mannitol is now well established, but what I'd really like to focus firstly is on the issues of the management of seizures following traumatic brain injury, and then some of the surgical aspects. We've had quite a long interest in seizures post-traumatic brain injury, and that has led to us putting in a grant application to the National Institute for Health Research, and they have funded this study called MAST, the Management of Seizures After Traumatic Brain Injury, and that is designed to answer two research questions. If a patient has a seizure after a traumatic brain injury and they're started on an anticonvulsant drug, how long should that drug be administered? Is a longer course of anti-epileptic drug superior to a shorter course in patients who have early seizures during acute hospitalization? So that is one of the questions we seek to answer. The second question is there a role for prophylaxis? So in TBI patients who have not suffered a seizure following a TBI, is a 7-day course of an anticonvulsant drug, and we recommend either phenytoin or Keppra, superior to no drug in the prevention of post-traumatic seizures. So we started this MAST trial of prophylaxis in March 2021, and the recruitment, as with many of these trials, has not quite been what we've anticipated, initially through COVID reasons. Fortunately, we have been able to increase the recruitment both in MAST prophylaxis and also in MAST duration. Currently, this trial is predominantly United Kingdom centres for both prophylaxis and duration. And what we're keen to do is reach out to other nations in the world, and we would very much like to discuss with collaborators through a global network in India as to whether this MAST trial would be possible to recruit in Indian centres, and perhaps that we could discuss that later. In terms of the surgical management of traumatic brain injury, as you're aware, there are a number of pathologies that are seen: intracerebral hematomas, diffuse brain injury, acute subdural hematomas, and chronic subdural hematomas. And what we've tried to do over the last 2 decades is to try and generate some of the evidence for the surgical management of these patients. So this was one of the initial trials that was run by Professor David Mendelow from the University of Newcastle. And here was a patient with a traumatic intracerebral hematoma. The question is this a patient who needs early surgery, or is this a patient who can have a medical or conservative treatment, at least initially? The STITCH trial randomized 170 patients. It was stopped prematurely for logistical reasons and failure to recruit adequate numbers in the UK National Health System. What it did show, even in 170 patients, was a marked reduction in mortality if you operated early on these mass lesions, with a tendency or a trend towards more favourable outcome. Some unanswered questions, but I think the feeling is that often these mass lesions within the brain itself are probably best surgically evacuated, if significant in terms of size and mass effect. The removal of an intracerebral hematoma is an internal decompression. The alternative approach is, of course, an operation that you're familiar with, an external decompression, and that is a removal of a large piece of bone to try and control brain swelling. The scalp is placed back over the swollen brain, the objective being to open the tight box and reduce intracranial pressure. And you're aware that this operation can either be performed as a unilateral procedure. This is what is generally advocated for acute subdural hematomas with mass effect in midline shift, or our preference for diffuse brain injury, is the bifrontal decompressive craniectomy, which has now been described in terms of nuances and improvement in surgical technique. We've learned to take the pericranium as a separate layer, to preserve and repair, if necessary, the frontal sinuses, to remove the bone completely over the superior sagittal sinus, and also, if possible, to divide the falx at its most anterior extent. If you're going to do this operation, we would recommend a minimum craniectomy size of 12 centimetres, and there are many controversies in terms of subsequent skull reconstruction. Cranioplasty is a second operation. There is therefore interest in leaving the bone flap in and leaving the bone flap floating, so-called hinge craniotomy. Our preference at the moment in the UK tendency towards using a titanium reconstruction for cranioplasty. What remains clear is the optimum timing for that procedure, and I think there is more work to be done. The trials have now all finished recruiting. Two have been published, DECRA and Rescue ICP, and Rescue Acute Subdural is in submission. Rescue Acute Subdural is a trial of primary decompression for acute subdurals. When you take out the acute subdural, should you replace the bone flap or leave the bone flap out? Of course, replacing the bone flap has the advantage that you do not need to undertake a cranioplasty. The disadvantage is that it won't help control brain swelling in that perioperative period. In terms of diffuse brain injury, you'll recall there are two trials, DECRA and Rescue ICP. I'm very briefly going to summarise the results of these trials. They've been presented previously, but I think what would be helpful is to look at how the results of these trials can help us change our practice to try and improve outcome for patients. So just to recall, DECRA was run out of Melbourne by Jamie Cooper and Jeff Rosenfeld. It randomised 155 patients with raised intracranial pressure greater than 20 millimetres of mercury with diffuse injury within 72 hours. And the results showed that those who were randomised to a decompressive craniectomy had no difference in mortality, but a higher rate of unfavourable outcome compared to those with standard care. And when you look at the ICP tracing, this is the most important figure, I think, in that publication, which showed that patients randomised to decompressive craniectomy had a greater reduction in intracranial pressure below 15, but actually the take-home message was those who were managed medically had very good control of their ICP, certainly below what we would regard as our threshold of 25. So decompression does gain you a little bit more ICP control, but these patients were actually well managed in terms of their ICP control medically. In parallel, we undertook the Rescue ICP trial. I showed you this algorithm yesterday in terms of the management of intracranial pressure, keeping it below this target of 25. About 15% of patients remain very challenging to treat despite these initial 4 stages of therapy. And in these, there has been in the past talk about advanced medical treatment, so barbiturate coma, or a secondary decompressive craniectomy. So just to remind you, Rescue ICP was a rescue intervention. You've tried to control raised intracranial pressure with a number of therapies. That has failed, and then there is the option at this last stage 5 to randomise the patients to advanced medical management, which may include barbiturates, versus surgical management of decompressive craniectomy. Having interpreted the results and tried to change practice, there's 2 things that I think we didn't do so well with Rescue ICP, and I think if we were ever to revisit that, there's 2 things that we should have done differently. The first thing is the primary endpoint. Classically, studies of head injury have looked at primary endpoints of 6 months. I think that is too early, and certainly a number of patients change 12 months and 24 months. So for Rescue Acute Subdural, the following trial, the primary endpoint is 12 months And the other issue I think it's important is that we didn't have the resource to collect the cranioplasty data, material and timing for rescue ICP. Much has been talked about quality of life and disability after traumatic brain injury, and I think it's really important to understand what these categories of the extended Glasgow outcome actually mean, because at the extremes, death, vegetative state, good recovery, it is fairly straightforward, but severe disability is divided in the 8-point scale into an upper and a lower category. And the lower severe disability are people who are institutionalized, hospital, rehabilitation or nursing homes. They are dependent on others for care, whereas upper severe disability are patients who are at home. They need to be independent for at least 8 hours to be in the category of upper severe disability. So they are able to look after themselves. To some extent, they're not independent outside the home, but I think it is important just to understand what we mean by these terms. Rescue ICP, again, a major international effort. This was a summary of the results. At 6 months, there was a marked increase, a difference in mortality between medical and surgical patients, nearly 50% in the medical group, 27% in the surgical group. But note that the surgical patients had a higher incidence of vegetative state and lower severe disability compared to the medical patients, and a slightly higher rate of upper severe disability, or better. But when you go through to 12 months, there was improvement in the surgical patients such that more of the surgical patients moved into this better outcome group, and that actually became significant at upper severe disability or better at 12 months. So more recently, we've now published the 24-month data from Rescue ICP. So this was published in JAMA Neurology, and I think this is very important data because it shows, again, some important changes with time. We saw changes between 6 and 12 months, but we also see changes between 12 and 24 months. And I think the most striking point here is that we see improvements in the grade of the extended Glasgow outcome scale. And these improvements appear to be greater again in the surgical group compared to the medical group, such that if you now compare surgical and medical groups at 6 months, 12 months and 24 months, you do tend to see this shift and improvement in the surgical patients. And in fact, if you look at this difference between the brown and the blue here, the moderate disability with time, you can see this trend in the surgical patients. Having said that, I think it's really important to recognise that decompressive craniectomy does still lead to proportion of patients in the vegetative state and the states of lower severe disability. That's important to recognise. But I think, on the other hand, there are a number of patients now who are getting back to the moderate disability levels or better. So where does that leave us? Some of these patients, there is no doubt in my mind that it is the right thing to do. In other patients, we are concerned about some of the results from decompressive craniectomy. We need to get smarter about patient selection. One way to do that is to try and refine the diagnosis. This is not just purely an issue of cerebral edema and swelling of the cerebral hemispheres. When we begin to undertake more advanced imaging beyond CT, you can see pathology such as brainstem lesions that are not visible on a CT scan. If you have a severe brainstem contusion or laceration, then your prognosis for recovery will be defined at the level of that brainstem lesion, and decompressing the cerebral hemispheres will not impact on that recovery. So I think we just need to step back a little bit and think about patient selection. And as I've said, we also need to refine cranioplasty timing and technique. So I presented some of the results, but where does this lead us? So I think Rescue ICP does provide data. It's quantitative. It provides data that will hopefully guide the management of patients with raised intracranial pressure for their clinicians and their families. In my mind, it is beyond doubt that this operation saves life. There is a marked reduction in mortality. What I think is important now to recognise is that this is not a short-term issue. The 6 months is too early, and at 24 months, the decompressive craniectomy subjects continue to improve. So if we go to this what-if analysis, if you take 100 patients and you treat them with decompressive craniectomy while the medical attempt, then what will happen? You save 20 more out of 100 lives, so that's a significant number. And in terms of those 21 extra survivors, they break down approximately into thirds. A third are dependent in terms of their severe disability or vegetative state. 7 are now independent at home for at least 8 hours, and 8 will be independent outside their home. So about a third dependent, a third independent at home, and about a third independent outside the home. What we've also learned is people say, well, rescue ICP, was that a negative trial, was it a positive trial, what did it show? Well, that is probably unhelpful, and also unhelpful is what we call this loaded term. So we talk about favourable outcome and unfavourable outcome. What is favourable for one family maybe not be favourable for another, and vice versa. And patients and families will accept different levels of disability. That may be within centres, within nations, or across nations. And I know, having presented these results in various countries throughout the world, what is perceived as favourable or unfavourable has important cultural and ethical implications. So I think we're not there to say whether you should or shouldn't do a decompressive craniectomy. I think it's our role to provide the evidence to try and give people some guidance in terms of prognosis following that intervention. So if we avoid using these loaded terms, what can we say? I think DECRA showed that an ICP threshold of 20 millimetres of mercury decompression was not the best option. These patients could be managed medically. If you've tried all other medical interventions and you've failed, decompression as a rescue therapy reduces mortality, and about a third of the patients are dependent and 2/3 are independent at home or better. But you have to be patient and look at this 24-month data. So these have been translated into the Brain Trauma Foundation guidelines. The level 2A evidence is stated that secondary decompressive craniectomy performed for late refractory ICP is recommended to improve mortality and favourable outcomes. Again, I would just be a little bit cautious about the word favourable. Mortality, yes, and I think there are, as I said, large numbers of patients who are now getting back to more unsatisfactory quality of life. Beyond 24 months, there's now some 10-year data. Again, some investigators have followed these patients out for longer. That, on the whole, seems to be encouraging. But just remember that what Martin Smith said, who chaired the Data Monitoring Committee, that we have to look at this operation in the context of the clinical indications and consideration of individual patients' preferences, quality of life expectations, both for them and their family. Rescue Keeps and Joy is finished recruiting. We're hoping to be producing the results within the next few months. This was a trial, as I said, of leaving the bone out or placing the bone back following evacuation of an acute subdural. It was a challenging trial to conduct because the randomization was performed interactively. We're very grateful to Indian centres for their fantastic contribution to this trial. A number of Indian centres, particularly AIMS in Delhi and Nimhans in Bangalore, who were tremendous in terms of making sure that we had enough patients to do this. Of course, we also have the Christian Medical College, and you can see this is the distribution of centres, but the Indian centres, I think, made a contribution such that this trial has become successful in terms of its recruitment. And again, I would reach out to you to see whether you could assist with the MAST anticonvulsant trial. The consensus statement for decompressive craniectomy has been published. It gives some guidance. I think what we do need to do going forwards is look at the role of of this floating bone flap and hinge craniotomy. So I've talked so far in the lectures about a bit about classification, pathophysiology, IT management and monitoring, clinical trials. I'd be happy to take questions now or defer questions until after the final 10-minute talk on challenges in global neurotrauma. Really important to acknowledge the patients and their families who participated in these trials, the trial steering committees and data monitoring committees, and the National Institute for Health Research and other funding bodies that have helped fund these trials, colleagues in Cambridge and beyond. And as I said yesterday, I'd like to invite you all to the International Neurotrauma Conference in 2024. Thank you very much for your attention.
Hutch?
Yes.
This is Matthew Joseph.
Matthew, how are you?
I'm doing well, thank you. Can we go ahead with the next talk as well and do questions at the end?
Perfect. That would be lovely. Thank you.
Thank you.
So initially much of our work focused on intensive care and surgical management and trials, but about 10 years ago the UK government committed to spending a portion of GDP, gross domestic product, on overseas development assistance, and in fact the government is spending about £10 billion on overseas development assistance. A lot of that is in terms of aid, but they recognised about 6 years ago that there was much that could be done in terms of global health, and funded about 14 research groups, a number of different pathologies across the whole of medicine to try and improve outcome globally. And we were fortunate in a successful bid for what was initially a global health research group on neurotrauma. That was the first generation. Neurotrauma is a renewal, the Global Health Research Group on Acquired Bone and Spine Injuries, which is starting this year. As of November 2022, so in November last year, the world's population went over 8 billion, so that was a major landmark. Of those 8 billion work from the Atlantic Commission, and others realised that about 5 billion of the 8 billion people do not have access to adequate surgical and anaesthetic care. So the Global Surgery 2030 initiative looked at evidence and solutions for achieving health, welfare and economic development, and they have categorised surgery according to must do, should do and can do. The three index procedures that they feel should be started and everybody should have access to is the general surgical operation of laparotomy.
Hutch, sorry,
Yeah.
we are having problem with the slides. Do you think you'd share slides from your end?
Yes, I'm showing them. Are they coming?
No, they're not coming through.
That's strange. Let me try again. I may need to reshare the screen.
Yes. Now we have
Are
it.
they there?
Now we have
Great.
it. Yes. Thank you.
Did you do any of the slides? I think what I said at the beginning, in summary, we were fortunate in achieving the funding for what we call the NHR Global Health Research Group on Acquired Bone and Spine Injury. And as I said, in November 2022, the world's population went to 8 billion, of whom 5 billion do not have adequate access to surgical care. And there's these three index procedures that I think it's recognised where the greatest need is, and that is laparotomy for abdominal emergencies, caesarean section for obstetrics, and treatment of open fractures for orthopaedics. But you can see in this second category of should do, there is a neurosurgical operation, evacuation of intracranial hematoma, both traumatic and non-traumatic. There is, as well as the whole of surgery, a huge unmet need in terms of the delivery of neurosurgery. So there's about 22 million patients that experience neurosurgical disorders or injuries that require neurosurgical care. About 14 million of these primarily require surgery. There are approximately 50,000 neurosurgeons worldwide, but there is a huge discrepancy in the number of neurosurgeons per population across the globe, and there are probably, we think, between 190 and 200 countries in the world now, of whom 33 have no neurosurgeons at all. And it's been estimated that we probably need around 25,000 more neurosurgeons to address this unmet need of essential neurosurgical cases. Now, most of these are in low and middle income countries. So the official development assistance funding will need our global group. I know that Matthew was very, very helpful in terms of the first generation. We had a launch for that, and now this new group has been formed. The difference between the new group and the old group is that the old group focused purely on neurotrauma, head and traumatic brain injury, whereas the new group takes neurosurgical pathology beyond that and includes traumatic spine injury, neurosurgical aspects of stroke, brain infections, and cerebrospinal fluid disorders and hydrocephalus. Historically, a lot of this funding has been spent on communicable infectious diseases. With increasing industrialization and an aging population, the non-communicable diseases, surgical diseases and injuries are becoming increasingly important. And I love this map of the world that Tony Fagaggi has on his wall in Cape Town, which shows the world, what we could call the correct way up. The world, of course, is a globe. It could be perceived either way. But I think having the globe this way up really emphasizes the problem that trauma causes 11,000 deaths per day. When we heard horrendous figures during COVID, but this is a silent pandemic. This is not talked about. 11,000 people dying every day from trauma. Many of these are from head and spine injury, and about 90% of them are occurring in low middle income countries. So an update on the main findings from the previous group. One of the main outputs was the GENOS study. So this was this was a snapshot of the management of traumatic brain injury patients over a 2-week period. Any hospital in the world who treated patients surgically with traumatic brain injury was eligible to join the trial, and the results were published in The Lancet Neurology last year. What were the main findings of GENOS? What we did was divide the world into Human Development Index categories: very high, medium, and low. Again, it was a major international effort. About 57 countries contributed patients across 159 hospitals. The overall mortality was around 18%, but the most striking finding was that the odds of mortality relative to very high Human Development Index tiers were greater in the medium tier, greater in the high tier, but importantly, in the low tier, the mortality was less. And the message from that is, I think there are many patients who are dying from head injury who are not able to access a hospital in the first place. And I think if we can begin to address that, then we can improve outcome. As I said in the previous talk, in the United Kingdom we are seeing a change in the mechanism of injury, away from road traffic collisions to falls, particularly in the elderly. And this now is the demographic of the mechanism of injury in different countries across the world. And you can see in Europe it is predominantly falls. Interestingly, Canada is road traffic collisions, as are parts of South America, and India, the parts of Asia, it is road traffic collisions that have become the major cause of injury. We've also looked at the median time from injury to surgery, which is pretty shocking, at around 13 hours globally. The median time from injury to surgery increased as you move from the very high HDI to the low HDI, but even the very high HDI countries are doing very badly in getting patients to operative care in a timely manner. But I think this data is quite helpful in terms of trying to lobby and improve resources to get patients A, to hospital, and B, through hospital into the operating theatre more quickly. And then if you look at the type of surgery that's performed, again in North America and Europe, it tends to be acute subdural hematoma, but what was reported in other parts of the world was a high incidence of extradural hematoma, and that is what we found in the centres that contributed data from India. So I think what we've shown is that there is an issue in terms of access to care, delays to surgery, lack of access to CT scanning or funding for CT scanning, intensive care, ICP monitoring and rehabilitation. The statistic at the bottom is interesting in terms of discharge from hospital to rehabilitation, and the difference is, I think one of the things we really do need to address is rehabilitation, and we've been doing some work in a number of countries looking at how families can assist in rehabilitation. So the studies have demonstrated that there is an issue of access. The other thing that we need to try and do is the Brain Trauma Foundation guidelines are all very well if you work in a very sophisticated centre in the United States, but other parts of the world, parts of Europe and other parts of the world where access is not so good, we need to apply appropriate clinical practice guidelines tailored to the resources available. These need to be stratified within resource constraint. But having said that, there are initiatives over the past 5 years to try and improve resourcing, global, institutional, governmental and investigator-driven. Investigator-led, so there is the NIH Fogarty funded Global Neurotrauma Initiative in South America, and then, as I said, we've had our Global Health Research Group on neurotrauma. Prevention is important. I'm not going to say any more about that. Maybe we could pick that up in the discussion. I think I heard that you were discussing it a little bit earlier. We could also get smarter about how we design protocols and pathways. Systems engineering is an approach where you can model the current management of a pathway of a patient from the scene through hospital care, rehabilitation and home. We did some work in Myanmar to model improvements in care in one hospital. We were then able to implement these changes in care from the pathway and the synthesis that we did through systems engineering. This was very cost and time efficient. It did lead to improvement in the pathway and management in Myanmar. Sadly, as you're aware, events became very, very difficult. We lost contact with our collaborators, but fortunately we were able to produce this output in BMJ Open. The systems engineering approach is something that, again, we'd like to pick up in other countries. Can we get smarter with technology? There's a lot of interest in the handheld infrascanner. Some of the results on this are now encouraging. We've piloted this in a number of countries, predominantly in South America. We're also using optic nerve sheath diameter to measure intracranial pressure as a surrogate. That's something that we use on the intensive care unit in Cambridge now if we can't put in an ICP monitor. And we are using SMS text messaging for follow-up. That's something, again, that we were pioneering in Africa, but we're actually using this in the UK National Health Service. So a lot of these technologies are applicable globally. What we're also trying to do is build research capacity. This isn't only about clinical practice, but by funding research fellows across collaborating partners and courses. Ricky Trevelli, one of my colleagues, and David Clark spend a lot of time in Zambia, and the number of neurosurgeons trained has gone from 2 to 8, with recent graduation of 3 fully qualified neurosurgeons within the last few months. Clinical trials, as I said, we're extremely grateful to Indian centres for their contribution to rescue acute subdural and would like to undertake more multi-centre international trials. And there are a number of resources now, the BMJ Research to Publication, other resources to try and guide the conduct of research across the world. So finally, just to focus on the aims of the new group, which is being launched next week. So this is brain and spine injury. It expands from TBI into spine, stroke, infection, and hydrocephalus. It will be a comprehensive research program, but also include training and educational opportunities for EMIC researchers and a global health fellowship exchange program. So the Society of British Surgical Surgeons are very keen that we introduce an exchange program. What we would really love to do is to buddy registrars, residents, fellows in different countries across the world so they can have a buddy partnership and visit each other's centre. I think that would be something really, really valuable, and I think everybody could benefit from that. Historically, we've been very doctor-focused. Again, I think that time is to change that, and we also need now to introduce nursing, allied health professionals and patients more embedded in the working group and project development. Classically, we have looked at success of research in academic publishing in high-impact journals. That is no longer adequate or correct. We need to look at how this research can cause impact at levels nationally, locally and internationally, producing guidelines that are stratified to the resources available, service redesign, training, clinical mentorship and research capacity building. So we're still going along with our standard themes: mapping care, understanding care, new technology and capacity building across these 5 conditions that are now being researched. The follow-on study from GMOS, the traumatic brain injury study, is that we've now created a global neurotrauma registry called GOTBI. So this is available again to any hospital that treats traumatic brain injury. The platform is there, the data collection process is there. If you're interested in joining GOTBI, that's the website, or please photograph the QR code. I think GOTBI is good because it provides hospitals with a platform to put in their own data so they can audit their own outcomes, but they can also contribute to the bigger data set, again taking us on from the next stage from GMOS. And finally, as well as the head injury at GMOS, we also have GMOS Spine, Global Neurotrauma Outcomes for Spine. This study again recruited large numbers of patients, well over 1,000 with spinal injury. This study is closing for recruitment shortly, and hopefully will give some idea of some of the issues in relation to traumatic spine injury. Finally, academic publications, as I said, are good, but we need to try and use this data to influence health policy. As doctors, I don't think it's a skill, it's not a skill that I don't have, but there are experts out there who can look at how we can use data in terms of health economics, advocacy and engagement, and convince governments to put more money into neurosurgical conditions. People who are good at that are health economists, so there is now a formal partnership between the Royal College of Surgeons and the London School of Economics. We need to continue to lobby at big fora, such as the World Health Assembly. I think that's an important way by which we can project our voice. So to conclude, there are still many issues: prevention, care, research. There has been progress, but there is always more to be done. And I think this concept of reverse translation is really, really important. By buddying the trainees across different countries, I think the trainees, particularly UK training, could learn an awful lot about neurosurgery in the world, and some of the technologies that are being introduced elsewhere. The reverse translation is going to be really important going forwards. So if anybody's interested in talking about these buddy relationships and pairing trainees across different units, then again, please let me know. And finally, we've got to make sure that we transform research beyond scientific publication into policy. I'd like to thank our many collaborators across the world, and we're particularly grateful to the fantastic collaboration that we've had with the centres in India. Again, please come to Neurotrauma 2024, and thank you again for the invitation to speak. I'm really sorry, as I said, that I'm not able to be with you personally, but really look forward to coming to ANTC in 2024. Thank you for listening, and I'm really happy to answer any questions.
Thank you, Hutch. Unfortunately, we're running rather late, so we won't have time for very many questions. We're like 40 minutes beyond time.
Okay,
The only question I'd like to ask, I mean, for the benefit of people here, is if people want to join these initiatives, who do they contact?
So I think the easiest way to do that at the moment is to email me personally. We've got the launch coming next week, and then we'll have a more formal email connection. So what's the best way? Matthew, I think you have my email, or I can put if I put my email in the chat, then please share my email address with everybody. I think what would be really good is to try and get some more recruitment to the master anticonvulsant trial would be one thing, and then I think to get trainee exchange program established again would be something that we'd really like to do with you.
Sure, we'll do that. Thank you. Thank you very much.
All right, I'll sign off now. Apologies again, and really look forward to a visit to India in 2024.
Thank you. Thank you.
Thank you.